is on a very interesting topic. Is clopidogrel the new aspirin? The speaker for this is Dr. Pankaj Manoria, and I hand over the mic to the chairperson, Dr. Brajesh Srivastava and Dr. S.K. Parashar. Dr. Brajesh Srivastava, please initiate the session.
Yeah, thanks a lot, Dr. Manoria, sir, for this beautiful meeting, and it's discussions are very enlightening. So we are coming to the conclusion of this today's meeting, and the last talk is by Dr. Pankaj, and he shall be discussing about the clopidogrel. The topic is the clopidogrel new aspirin, because we always, as a clinician, as a cardiologist, we always try to find out balance between ischemic risk and bleeding risk, and there is always a challenge to balance these two parameters. So Dr. Pankaj is going to enlighten us what is their new in the antiplatelet management with respect to clopidogrel, and is the aspirin is still relevant today, or what are the further his thoughts on this. So Dr. Pankaj is a well-known faculty at national and international forum. Over to Dr. Pankaj.
Okay. Thank you, Dr. Brajesh, for the nice introduction. And are my slides visible?
Yeah.
Yes.
And I'm on. Okay. I've changed the topic slightly. The topic given to me is clopidogrel the new aspirin? I've changed to clopidogrel is not the new aspirin, it's a super aspirin, I can say. And I have enough evidence to support what I'm saying. So, I totally agree that aspirin was a wonder drug, no doubt. Since when it was invented by Bayer way back in 1898, and we have been using aspirin in almost all acute coronary syndromes, in strokes, in peripheral artery disease, and it has done a wonderful job, no doubt regarding that. But as the saying goes, change is the law of nature. Everything in the world has changed. The way we have traveled has changed. The way we communicate has changed. Our eating habits have changed. Similarly, the way we treat chronic coronary syndrome patients, our antiplatelet strategy also needs a change. So is clopidogrel the new super aspirin? Do we have the evidence, and can we prove it? I'll try to put the evidence in front of you, and it is up to you all to decide whether it's a super aspirin or not. Now, if you see the older guidelines, they recommend that we should use aspirin in all patients of a chronic coronary syndrome, post-MI patients, peripheral artery disease patients, stroke patients. So can we replace this aspirin with clopidogrel? This is what I'm supposed to speak upon. Now, we know the long-term maintenance therapy for secondary prevention in CCS. By long term, I mean to say, if the patient has already undergone angioplasty more than 1 year, chronic stable angina patients, stroke patients, peripheral artery disease patients, in all these patients, we used to write aspirin for lifelong. Now, my motto is that can we replace that group of patients who are receiving lifelong aspirin with clopidogrel monotherapy instead of aspirin monotherapy? Now, whether which is superior, aspirin or clopidogrel, I'll take you way back in 1996. This famous article published in Lancet, the Capri trial, which was a randomized controlled trial assessing the efficacy and ischemia, efficacy as well as the bleeding endpoints of clopidogrel versus aspirin. And what they found was, in the Capri trial, clopidogrel was superior in terms of efficacy in reducing as compared to aspirin, with a significant p-value. Long-term administration of clopidogrel to patients with atherosclerotic vascular disease is more effective than aspirin, reducing the combined risk of ischemic stroke, myocardial infarction, and vascular death. And the overall safety profile of clopidogrel was as good as of that aspirin. So, 1996, we had the evidence that clopidogrel was better than aspirin, and when we use that as a monotherapy. Now, since then, a lot of advancement has made over the last couple of years. Lots of randomized control trial have been done studying which monotherapy is better, whether clopidogrel or aspirin. And one of the largest trial was the PCI host exam trial. And this was a Korean study. And what they did was, in this study, almost, you can say, more than 5,000 patients, they were randomized. All these patients have undergone angioplasty more than 12 months prior. So they received DAPT for 12 months. And after 12 months, these patients were randomized into monotherapy of aspirin or monotherapy of clopidogrel. We all know that we use DAPT for 12 months after PCI or after acute coronary syndrome. And after 12 months, we switch over these patients to usually aspirin. But in this trial, they study whether when you after giving a 12 months of DAPT, can we switch these patients to clopidogrel instead of aspirin? And this is how they randomize these group into two groups. And what the primary endpoint was a composite of ischemia as well as the bleeding. The combination of all-cause death, non-fatal MI, stroke, readmission for SCS, or major bleeding. This was a composite primary endpoint. And what they found was the primary endpoint, there was almost a 27% reduction in the primary endpoint in favor of clopidogrel. As you can see, divergent graphs. When they look into the individual secondary endpoint, that means the thrombotic as well as the bleeding group individually. And what they found was there was almost a 32% risk reduction in ischemic endpoints. That means is reducing MACE, reducing MI, reducing stroke in favor of clopidogrel than aspirin. That means clopidogrel was more potent in reducing ischemia as compared to aspirin. When they looked into bleeding endpoints, they found that clopidogrel was more safer than aspirin. That means the bleeding was reduced, as you can see, almost by 32%. So you have a 32% risk reduction in bleeding, you have a 32% risk reduction in MACE, and you have almost 27% reduction in the composite primary endpoint. So this trial was a clear-cut suggesting that clopidogrel is the winner, and clopidogrel is the new super aspirin when it comes to maintenance therapy with antiplatelets. Now, another trial I can only few months back only, this Smart Choice 3 trial. This was again a randomized controlled trial, again studying the same group of patients, clopidogrel versus aspirin monotherapy in patients high risk after PCI. And what they did was, again they randomized the two groups. One they give clopidogrel, other they give aspirin. And what they found was the primary endpoint, which is again the MACE. There was almost significant risk reduction of almost 29% in favor of clopidogrel. So again, clopidogrel was found to be more potent in reducing MACE. The MI reduction, particularly, what we are concerned with, our patient should not end up with acute myocardial infarction. You can see almost 2 times more reduction of MI, future MI with clopidogrel than aspirin. Bleeding endpoints, you can say here the bleeding was, there was no increase in the risk of bleeding. I can say the bleeding was at par with aspirin, because people are concerned that bleeding may be more with clopidogrel. But here in this study, almost bleeding was as same with aspirin as compared to clopidogrel. I can tell you another evidence in support of this. The famous Panther trial, the prime investigator was Professor Marco Valmiki, which was presented 2-3 years back in ESC, the Panther study. Again, the same group of patients, same meta-analysis. The conclusion was, again, when they compared aspirin with P2Y2 inhibitors, again, the winner was again P2Y2 inhibitor. It may be ticagrelor or clopidogrel monotherapy. You can clearly see, if you see all these meta-analysis, all these all are favoring the left side. The left means P2Y2 inhibitor on the left side, aspirin on the right side, clearly suggesting that the winner was P2Y2 inhibitor, that was the clopidogrel. Major bleeding, as you can see again, major bleeding was also more in support of clopidogrel or P2Y2 inhibitor that compared to aspirin. So the Panther analysis concluded that as clopidogrel or P2Y2 inhibitors are more potent, at the same time, the bleeding events are less. This is to study the secondary endpoint of different subgroups. You can see CV mortality is almost the same, but MI was less, stroke was less, ischemic stroke was less, hemorrhagic stroke was less, definite stent thrombosis was less, and GI bleeds was also less, with favoring P2Y2 inhibitor as compared to aspirin. So, should aspirin be the second line antiplatelet in CAD? That means the first line should be clopidogrel. That was studied in the ESC meeting, and there was a lot of debate whether we should replace clopidogrel with aspirin based on this Panther meta-analysis. So besides, I've told you host exam trial, I've told you Smart Choice, I've told you Panther. I can tell you number of other recent studies, such as this article was published in JACC, P2Y2 inhibitor or aspirin monotherapy for secondary prevention of coronary endpoints. I can present you, this was a Chinese registry, Fuai PCI registry. Again, the same conclusion that there was less MACE with clopidogrel than aspirin. So we have the Korean study, we have the European study, we have the American study, now the Chinese study. So I can tell you on every subgroup of continent, every subgroup of throughout the globe, they have lots of studies going on, and all these are coming to the same conclusion that as clopidogrel is more potent in reducing MACE, and the bleeding can be less or at least same as compared to aspirin. Again, this is again the European study, European meta-analysis by Devika et al., which was published in the European Heart Journal. Again, seeing same thing. You can see the group in the bottom. You can see. Sorry. Major adverse events, MI, stroke, all cause mortality, or were less with P2Y2 inhibitor. So clopidogrel was superior to divine aspirin monotherapy in secondary prevention. This was again published in TCTMD. So I can tell you all, there are multiple meta-analyses. I think the time will not permit me to describe all of these. But so far I have described all these meta-analyses or studies, randomized controlled trials, all suggesting that same thing, that clopidogrel is better than aspirin. So I can give you two simple reasons to replace aspirin with clopidogrel. What we want whenever we use antiplatelet for maintenance therapy, we want that it should be efficacious. By efficacious, that means it should reduce myocardial infarction, it should reduce stroke, and it should reduce any ischemic events. Clopidogrel, with all the studies which I have shown, clearly is the winner. It is more efficacious. The reason being, the main, if you see the pathway for platelet activation, the main pathway for platelet activation is P2Y2 inhibitor. If you block P2Y2 receptors inhibitors, almost 80-90% of the platelet activation can be controlled. Aspirin blocks cyclooxygenase pathway. Cyclooxygenase pathway contribute only 10% for platelet aggregation. So if we are blocking P2Y2 inhibitors significantly, we can reduce ample amount of platelets aggregation, and that is what is required. That is why in all these studies, if you see, blocking P2Y2 inhibitors promotes more platelet inhibition vis-a-vis blocking cyclooxygenase pathway. That is why clopidogrel was more potent than aspirin in reducing MACE events. All these studies which I've shown, again, I've compared in a single slide, favoring clopidogrel as compared to aspirin in reducing MACE. Second simple reason why I replace aspirin with clopidogrel is because I want my patient to have less bleeding. It should have less side effects. And we all know that aspirin is a GI intolerant. The chance of GI bleed is very much with aspirin as compared to clopidogrel. The simple reason that aspirin can cause GI ulcers. If you see the meta-analysis, the randomized controlled trial, when they analyze bleeding with aspirin as compared to clopidogrel, they clearly found that there was more GI bleed, more other intracranial bleed, more bleeding with aspirin as compared to clopidogrel. So the drug which is more potent, clopidogrel, the drug which is cause less bleeding is aspirin. So we have two solid reasons why one can replace aspirin by clopidogrel. If we see now, coming back to the guidelines, last year only, 2024 ESC guidelines were published of chronic coronary syndrome. If you see, guidelines clearly mentioned in patient of chronic coronary syndrome with prior MI or remote PCI, that means more than 1 year, clopidogrel 75 mg daily is a recommended and safe and effective alternative to aspirin monotherapy. They are clearly mentioning it's a very safe and an effective alternative to aspirin monotherapy with a class 1A recommendation. I can say, for aspirin, I can say the retirement is just ahead, because every good thing comes to an end. It has done a wonderful job in the past, but I think the time has come to retire aspirin and replace with clopidogrel, which is a better drug, more efficacious, and with less side effects. So we have to change the proverb we used to say, an aspirin a day keeps the doctor away, to a clopidogrel a day keeps the doctor away. So time to replace the old with the new. Similarly, the time to replace aspirin with the new clopidogrel. This is my last slide. I just this is a small poem which was written by Alfred Tennyson. The ring out the old, ring in the new, ring the happy bells across the snow. The year is going, let him go. Ring out the false, ring in the true. Thank you everybody.
Wonderful deliberations, Dr. Pankaj, and you have very well shown the robust data. I have a point here in the Panther trial and the other trial where they have mentioned the P2 inhibitor versus aspirin, where the results might be biased because of use of other P2 inhibitor, prasugrel and ticagrelor. So the robust data came from the recently Smart Choice 3 and a host exam trial, and also a Smart Choice 1 trial, which was 2 or 3 years earlier. For the sake of the audience, I would like to stress that what we are talking is about DAPT after 1 year of DAPT, after any event of ACS or after any PCI. Not like initially after ACS, you should start clopidogrel. So we are discussing monotherapy, single antiplatelet after 1 year. And one more point is that, like in Smart Choice 3, high ischemic risk you have mentioned. So, can you give an idea, like what about high risk patients, like those are with left main bifurcations or non-left main bifurcations, high thrombus burden?
Yeah, high risk patients are those with complex angioplasty, who are diabetic, who had episode of multiple coronary events occurring within the last 1 year, had episode of stent thrombosis, CKD patients. All are these diabetic. All these are patients of high risk patients who have
Okay.
high thrombotic risk.
Okay. So even in those patients, even a monotherapy with clopidogrel after 1 year is safe. It's safe and less bleeding. Okay.
Very nice presentation, Dr.
Yeah.
Manoria. I mean, we always enjoy your presentations. The last one was hypertension, what's new. Copied all the slides, and I'm teaching my postgraduates from this one. Just a comment, there is a real world example I want to give.
Yeah.
My mother, who's very elderly, around now 90, around 90, but around the age of 82, 83, suffered a TIA, transient ischemic attack. And the neurologist told about, she was on aspirin and clopidogrel, but later on she could not tolerate aspirin. And very hesitantly, I continued clopidogrel because thinking that at least one should go. But I was always very nervous that because the neurologist had advised me 150 milligram of aspirin, that's it. No clopidogrel, nothing. 150 milligram of aspirin. That was about 5-7 years back. So I hesitantly took, but touch wood, she's keeping well and no episodes. So this is a real world, this is a real example in the house that it has been able to prevent both cardiac and cerebral events, even with a single drug where she could not tolerate aspirin, so she continued on. So I fully agree with your views, and I think this is going to come in future because it's a much safer drug. And most of the patients will tolerate it very well. So thank you. Excellent presentation.
Dr. Sandeep, you should also use rivaroxaban 2.5 milligram BD if it is a CVA case, TIA or stroke, along with single antiplatelet agent.
Okay, thank you, sir. Okay.
Yes, sir. As Dr. Manoria sir has said that like we can use rivaroxaban also, but there they have studied with a single this aspirin. There in COMPASS trial there was aspirin. Dr. Pankaj, is the clopidogrel resistance is still relevant today?
Yeah. I think somebody was asking this also, and this has been asked many a times whenever I present this my presentation. If you see, the clopidogrel resistance was never found to be clinically significant in any of these trials, which have all the antiplated trial, whether it's post exam, in the meta-analysis, or the Smart Choice trial. Though theoretically we say that yes, it is around 15%, 10%, but on practically none of these had the clopidogrel resistance clinically significant, the result would have been different. Patient would have landed up into more thrombosis, more MI, but the vice versa is happening. That means it is not clinically relevant. You got my point. Had it been that 25 had 15, 25%, we see the something in the articles, it's within 15, 25%. So if 1 out of 4 patients have clopidogrel resistance, we wouldn't have seen this much benefit, almost 35% more, less reduction, less MI with clopidogrel. So theoretically, you may ask, and also there have been studies which have tried to do platelet function test first and then switching over to these platelets. Again, that strategy was not found to be very lucrative. You might mean to say, even whether you use platelet function test before starting all these drugs, or you may not use it. It is up to your choice, but it's not making a lot of difference in these things.
Pankaj.
Yeah.
Pankaj.
Yeah.
One question.
Yeah.
Patient with 100% or 100 calcium score.
Yeah.
Still, we are using this aspirin. We are just listening from Dr. Rajiv Agarwal lecture.
Yeah. Yeah, I agree. They recommend whenever the calcium score is more than 100, you require some antiplatelet to prevent further MACE. And that antiplatelet, clopidogrel has never been studied in this aspect. They've already, because in our mind, it is said that monotherapy means aspirin. Whenever you require antiplatelet, it means aspirin. So they were never thought of using a clopidogrel. Now, clopidogrel has recently been emerged as a potent and more less side effects than compared to aspirin. So I think in days to come, we may replace these aspirin in that group of patients also. Because in that calcium scoring, they have already always used a monotherapy of aspirin versus placebo. They have never compared the two drugs. They just try to analyze that whether usefulness of aspirin in that group of patients as compared to placebo. It was not as compared to clopidogrel. It was never studied. But if we try to do a randomized control trial in that group of patients comparing aspirin with clopidogrel, I'm sure that clopidogrel will be the winner. I think there was some
Dr.
discussion
Pankaj,
with
hello.
there was some discussion
Dr.
with
Pankaj,
I think
hello.
yeah.
Dr. Pankaj, after completion of DAPT dual antiplatelet therapy after PCI, which monotherapy you would like to continue, either clopidogrel monotherapy or aspirin monotherapy? Which one you will prefer it? After DAPT,
That was a talk
after PCI?
yeah, that was a talk all about. But that talk
Yeah.
was all about that only. When we have used 12 months of DAPT, and then when we were staged to de-escalate, that means we were supposed to use only one monotherapy. And that subgroup of patient, I always prefer clopidogrel monotherapy as compared to aspirin, because for two simple reasons which I've just mentioned, it is more efficacious than aspirin. At the same time, the bleeding events are less.
And this will be for stroke also? This?
Yeah, it can be used for stroke. But stroke, the problem is stroke, the COMPASS trial, what they studied was a combination of aspirin along with rivaroxaban 2.5 milligram with only aspirin. So if we are a patient of history of stroke, the COMPASS trial suggests that we can use aspirin along with rivaroxaban 2.5 milligram twice daily. But in COMPASS trial, they didn't compare aspirin with clopidogrel. They compare aspirin plus combination of rivaroxaban versus aspirin alone. And what they found was this combination is very useful in reducing stroke in future stroke in these stroke patients. But in that subgroup patient, if you see in the COMPASS trial, the reduction in myocardial infarction was not significant. That means aspirin is very weak in reducing MI. If we can use, and though it is not studied, but COMPASS trial, if we want to incorporate COMPASS trial in our practice, we may use a combination of 2.5 milligram rivaroxaban twice daily, and we may add clopidogrel instead of aspirin, though it is not a recommended, but because it has never been studied. So in stroke patients, one should use rivaroxaban 2.5 milligram twice. That is recommended, and it has shown us almost 45% reduction in stroke. If the patient has already history of stroke, rivaroxaban should be used, and the one antiplatelet, and that antiplatelet can be aspirin or clopidogrel, because aspirin has been studied in COMPASS trial, but we don't have evidence for clopidogrel in stroke.
Also, Dr. Pankaj, one more thing. Whenever we do PCI in case of atrial fibrillation, we need a triple therapy. In that case, also, we have to combine NOACs with a clopidogrel is more safe rather than aspirin, or continue the triple therapy for a longer period of time. They say now we can reduce the duration of triple antithrombotic therapy up to 1 week, minimum 1 week.
Yeah, I think
very
valid point by Dr. Pankaj. I totally agree.
The COMPASS trial was Bayer's trial, and that was the reason why aspirin was preferred. Secondly, some subset of patients like increased LPA, aspirin still remains a choice because there's no trial of clopidogrel at the present state of time, maybe in future. Pankaj, the problem is there's no doubt clopidogrel is better in terms of bleeding and in terms of efficacy. But the other strategy which has been suggested, even recommended by ESC 2023, is that high-risk ischemic patients, they also recommend ticagrelor 60 milligram BID. So your comments?
Yeah, and somebody, Dr. Kushal was also asking this question in the chat. Ticagrelor monotherapy, that means that was ischemic 55 study that was studied low dose of ticagrelor along with aspirin, continuing DAPT with aspirin along with ticagrelor monotherapy 60 milligram twice daily. And that study, they found that those 60 milligram did reduce major adverse MACE, but the bleeding was more. So that is why they don't recommend to use ticagrelor beyond 12 months. The Pegasus trial. So it's the very high low bleeding is you can use. But
usually guideline now recommends only 60 milligram BID as monotherapy after 1 year.
If that is an option, but that is that high risk ischemic but low is bleeding risk, because bleeding risk will be more. If you use ticagrelor monotherapy, even in a low dose, the bleeding was more as compared to a monotherapy of aspirin.
So any other questions?
Usually it's a very potent drug. We need potent drug for only first few months of maximum 1 year of acute coronation, because at that moment, after 1 year, the platelet reactivity almost always reduces. So we don't need that potent antiplatelet. Ticagrelor is a very potent antiplatelet. It can cause serious bleeding issues also, and some side effects are also there with ticagrelor.
60 milligram is less potent anyway. So any other questions?
Is it useful in peripheral vascular disease in comparison to the silistazole? Should it be given isolated or with combination with silistazole?
You mean to say combination of aspirin or clopidogrel with silestazole?
Yeah, peripheral vascular disease.
Yeah, I got silestazole. We had used in the past also. We combined it with aspirin along with silestazole. Silestazole cannot be used in isolation for any peripheral vascular disease. We have to combine with the antiplatelet, the P2Y2 inhibitor or cycloxane inhibitor. Again, I say whenever we are using aspirin, I think in all these indications, we can replace aspirin with P2Y2 inhibitor. Suppose I have to use in peripheral vascular disease, I may use silestazole along combined with clopidogrel instead of aspirin. Or I can combine for PVD, I can also use rivaroxaban 2.5 milligram twice daily also for peripheral vascular disease instead of silestazole. And again, I can combine it with either aspirin or clopidogrel. But because aspirin is more studied in this combination in the COMPASS trial, I may prefer aspirin in that subgroup of patient along with rivaroxaban 2.5 milligram twice daily. Because clopidogrel was never studied. Because never studied doesn't mean it's not useful. You got my point? For peripheral vascular disease, I will use a combination of 2.5 milligram rivaroxaban along with aspirin because it was studied in the COMPASS trial. I may not use silestazole because we have more robust evidence with rivaroxaban in terms of COMPASS trial for PVD patients. So, but once the evidence was along with aspirin, I may use in that subgroup of patient combined aspirin with rivaroxaban 2.5 milligram twice daily.
I think at the present for PVD, it is aspirin plus rivaroxaban and no silestazole or no other anti. Then the results are excellent. I think with this, we conclude this session. Thank you very much for all of you for a good discussion and interactive. Hope to meet you again after a few months. Thank you very much.
Thank you, sir. Thank you.